Hi everyone, and welcome to the Tuesday webinar series, Chiropractic Economics Webinar for Doctors of Chiropractic. I'm Caroline Feeney, the Associate Editor of Chiropractic Economics magazine. Today's webinar, Musculoskeletal Laser Therapy, Integrated Clinical Protocols, is sponsored by Erconia. And as always, our program is being recorded and will be archived at Chiropractic Economics website, chiroeco.com/webinar, for 1 year. Our expert is on board here today to speak with you, and when his presentation is complete, we will follow with a Q&A period. You can submit questions throughout the presentation by clicking on the appropriate icon on the right side of your screen. We will do our very best to get to all of your questions, but if we run out of time, we will forward the remaining questions to our expert and then notify you via email when the answers we have posted on our website. Our expert today is Dr. Robert Silverman, the CEO of New York Chiro Care and a specialist in successful private practice in White Plains, New York, where he specializes in the diagnosis of joint pain and soft tissue management. He is here to help you understand the ways in which you can incorporate laser therapy in clinical practice. Dr. Silverman, thank you so much for taking the time today to participate in our webinar and for sharing your expertise in musculoskeletal laser therapy. We appreciate you helping our audience understand how they might benefit from adding this modality of care to their practices. Now, before we get started, please give us a brief background on yourself and your work with laser therapy.
We're going to talk about musculoskeletal laser therapy integrated protocols. As I said earlier, thank God everybody now can hear me. I'm very happy. I've been using lasers in my office for over the last 8 years. I found it to be a great tool to increase with clinical outcome with patients. My background obviously is in chiropractic, and I am a chiropractor. But as I went through chiropractic school, as I said earlier, there was a burning question in my head. And that burning question in my head was very simple. How could we fix the body from the inside out? And I do believe that low-level laser therapy has one of the two, if not the only tool, to truly help that. The other one clearly would be nutrition, and we could expand the field on that also. But low-level laser therapy helps heal the body from the inside out. Now, over the last 8.5 years, I've used all the different models that Erconia has to offer, and I've found them to be extraordinarily effective in clinical outcome. The thing that I like most is the FDA clearance. If you're going to take laser therapy into your office, please consider the concept of FDA clearance. FDA clearance for what? FDA clearance for specific conditions like plantar fasciitis and or for decreased pain and increased range of motion. So without further ado, since we're a little shorter on time now, I would like to move ahead and talk about musculoskeletal laser therapies, integrated clinical protocols. Great picture that we see right over here. I have one of my patients in there standing on a particular proprioceptive unstable board. So they're getting proprioception from their lower gate in a small foot yonder position with scapular stabilization, and I'm lasering him. I'm core lasering him. I'm trying to facilitate his core muscles with the laser, something called the base station. So you see how diverse and integrated laser therapy can be done. There's many different matters in which we can apply laser therapy. The quote is very simple in there, let there be light. I mean, we used to always use light and light energy in healing 30, 40, 50, and 60 years ago, and we've gone away from it. I'm very comfortable now seeing the reintroduction of laser light therapy. This slide explains really where we are in the concept of pathogenesis of cumulative trauma disorder. The top graph really depicts somebody who has an injury, has ample recovery, but unfortunately, or fortunately for them, the symptomatic injury threshold does not indicate pain and they have any complaints. That doesn't mean that they're healed, because I'm a big proponent that even though they were injured without pain, I'm really concerned about their movement. The second graph, the bottom graph, the pathogenesis of cumulative trauma disorder, truly depicts what we see every day in our office today. A great example of this would be carpal tunnel. Here we have an injury cycle. We have, unfortunately, insufficient tissue recovery between the cycles. Tissue damage accumulates, and we go over symptomatic injury threshold. We now have a dysfunctional joint, muscle injury, nerve injury, and or typically the patient complains about pain. This is what we deal typically with in the chiropractic office. Both have their place. Well, integrating laser into a practice, everybody knows Dr. Oz. He cleverly called the Aconia low-level laser the no-pill pain buster. Unfortunately for me, I wasn't on the Dr. Oz show at that point, but I said it was the most versatile healthcare tool of the 21st century. So you're seeing two different concepts. Oz really coined it, decreasing pain. I'm talking about its versatility. Its versatility and the ability actually to carry it anywhere you want. Many times I travel. I do about 40 weekends a year. I travel with it. You can put it in your pocket and offer the diversity or versatility it brings to different conditions. I'm a big proponent in a blueprint. I mean, what do you do when the patient comes in? So here's a basic blueprint. Number one, you must find the cause. Number two, explain the source. You know, most MDs, unfortunately, spend 18 seconds before they interrupt their patients. We as DCs have a little bit more, if you will, verbal give and take. I have a lot of students that follow me around, and they ask me the first class they should take. And I tell them communication. We have to be able to communicate with our patients. They want to know a short and a long-term goal. Laser provides that. In addition, you always have to determine an effective treatment time. And I'm in the Northeast. Everybody wants a shortened treatment time. Everybody wants it fixed yesterday, one visit, all sorts of ailments. So it's a nice little blueprint to look at when you start dealing with patients. One of the questions that a lot of doctors ask me is, what comes first, injury or pain? You know what? I'm not really sure it's the old chicken or the egg, but I know what is key in that it's called altered motor control. That is our fundamental question in which we should diagnose, altered motor control. So a sprained ankle, clearly we're able to treat a sprained ankle even though it has the highest recurrence rate of any injury. But when you think about the swelling and the change in the patient's gait, if you address the swelling and the injury, but you don't address how they move, the brain will change their motor control to address the injury. However, if you did not change or reprogram or engram that altered motor control, the person's always going to move in an aberrant manner. So we can apply a laser to help that also. This is the neuromusculoskeletal detonation sequence. I think this was put together beautifully by Dr. Yanda. This depicts upper and lower cross syndrome, and if you combine them, layer syndrome. In a nutshell, on the left, there's a pain dynamic. You have a tight muscle, a hypertonic muscle. That muscle neurogenically inhibits the balancing muscle. Together between the tight and the weak, or the tight and the neurogenically inhibited muscle, you get a strain point. At that strain point, there's pain. The patient has a complaint, and that is based on Sheridan's law in the 1950s of reciprocal inhibition. It would be as if I turned in front of the audience right now and you could visualize me doing a bicep curl like Arnold Schwarzenegger. You would hopefully see my bicep contract. However, what is my tricep doing at that point? It is neurogenically shutting off so it can lengthen to allow for the muscle contraction. When you look at the center part of this particular slide, the head is like a bowling ball. It's 9 to 12 pounds. For every inch that it's pointed forward in anterior head carriage, that's 1 to 2 times the weight. Washington Post just did a particular article on what they call text neck, which is the average person texting is 6 inches forward. They have an 80-pound child, as if an 80-pound child is on their back. The pressure, the damage done to the joints. There's literature to show if someone has an anterior head carriage that they have an increased SI radiculopathy. Enough of that. Now let's look at the upper cross syndrome, in that the pecs are typically tight, causing round-shoulderedness, and they're neurogenically inhibiting the mid and lower trap regions. The suboccipitals usually are tight, shutting off the deep neck flexors, the longest capitis, and the longest coli. The suboccipitals are an interesting set of muscles because they really don't have long endurance value. So typically somewhere between 3 days and 3 weeks, they fatigue. And that's why we see most people with acceleration, deceleration injuries moving forward. The strain points are intriguing in that the strain point is at the TMJ, the cervical thoracic region, and GH joint region. So yes, a postural imbalance will cause a jaw jut, anterior head carriage, and can lead to TMJ issues. The glenohumeral joint, if you're round-shouldered, you've repositioned your scapula not to allow your arm to go, and the GH joint now could have what we call an impingement, leading to a rotator cuff injuries and the like. When we go below the waist, the erectors are typically tight, shutting off the abdominals. Also, we have the psoas, probably the most indicative of lower back pain, a hypertonic psoas, shuts off the strongest muscle in the body, not per square inch, the glute maximus. This leads to lower cross syndrome. This leads to specific strain points at the TL junction, lumbosacral junction, and the hip. Stuart McGill, who I have a tremendous amount of respect for, really has done a wonderful job on the literature front. He has said immediate pain reduction can be achieved by altering muscular activation and movement patterns. Kind of piggybacks on what we said earlier about the altered motor control. Well, I'm a big proponent of movement. I think that movement is a key component. With that, it's all about movement. It's not about individual muscles. We have to look at the body as a whole, interconnected, integrative unit that has muscles, nerves, vessels, all interconnected to the brain, not isolating a muscle. The sole purpose of the body is to hold our brain and encase our brain and allow it to move. So I believe that the search is on. In that, I think that the search is on for a great answer for musculoskeletal injuries and things to help musculoskeletal injuries. So I think it all starts with laser focus. We need a laser focus. Now, laser is interesting in that it is an acronym. It is light amplification by simulated emission of radiation. It is a true focused beam of light that emits photon energy. It is a coherent light, meaning all photons travel in the same direction, at the same wavelength, at the same time. The best way to describe coherent light is the conversation that my wife and I have had multiple times about hairspray. I love to take the hairspray and put it right by my hair, and it all goes in the same spot at the same speed with the same wavelength. My wife hates it because she says my hair clumps. She loves to spray all around, but I like this hairspray close to the hair because it's coherent. She's doing an incoherent diverse because it's spraying all over the place. We want our laser light to be coherent, non-scattered. The cell is a machine driven by energy. In every medical tradition before ours, healing was accomplished by moving energy. Well, how does laser work? What are we talking about? The best answer, the most simplistic answer, the best way to explain it is using the basic principles of photochemistry. Light chemistry, light causing chemical reactions. What I like to talk about most about the concept of a light energy, people talk about laser light. Do you have to touch the skin? No. Can you be a few inches away? Yes. How does it work? It's truly the branch chain effect because a single photon can trigger a reaction in a cell that causes emission of several photons. They then trigger photon emissions in other cells like a chain reaction. So this actually counts for the fact that a signal can be multiplied to cause a rapid and regenerating flow of energy through the system. So the branch chain, the power of one. The metaphor would be as if you were to take a mousetrap with a ping pong ball. It's 8,270. Somebody actually counted this. Mousetraps with ping pong balls to put on a football field. If I had that one ping pong ball on the sideline, the laser, and I threw it in the middle, and it hit one of the mousetraps, there would be a cascade of reactions affecting everything. That's the branch chain effect of low-level light therapy. Well, how does it work? Well, it stimulates cell activation, in turn turning into a physiological activity. Healing is essentially a cellular process. Light energy initiates a cascade of reactions from our cell membrane, understanding that the light is absorbed by the cell membrane to the cytoplasm, to the nucleus, positively affecting the DNA. Simply put, it's cellular amplification. So the question, and the way it's been phrased to me, is how does this Star Trek medicine benefit our patients? The word photobiostimulation, if you were to Google that now, you would look up and see that photobiostimulation allows it to result in two basic responses. The low-level light therapy, LLT, increases cellular regeneration due to increased ATP production. Let me say that again. LLT, increased cellular regeneration, is increasing ATP production. Not only the production, but the efficiency of ATP production, whereas we're also increasing cellular communication due to a positive effect on the nervous system, biliving matrix, and the cell membrane. So in the end, when you're not sure and you have a laser, you want to talk about cellular regeneration and cellular communication. Cellular regeneration functions by laser therapy causing an increase of ATP production, which is a true precursor to cell division. Photons are absorbed by the chromophores on the cell membrane. These chromophores are light-emitting portion of the cell membrane. The absorption of these lights starts a chemical cascade through the cell membrane, leading to efficiency of ATP production. Cellular communication is intriguing in that the integrins, these are specific receptor sites on the cell surface. They link the cell to the surrounding environment. Now we know the cells are all interconnected, as I talked earlier. They're actually ligand binding sites which bind all of our extracellular matrix, our extracellular matrix being our cartilage, our ligaments, our tendons, and the big player, the fascia. Once they're able to affect the fascia, fascia is the key to interconnecting the whole body, because fascia is an intracellular signaler. So laser therapy, there's three major components that are integral to the beneficial outcome of light laser. The most important, and this is the take-home, the literature is vast, or if you will, there is a plethora of information and literature that indicates a wavelength, a specific wavelength, is responsible for influencing biochemical cascades. The wavelength that's most important is 635 nanometers, the wavelength of visible light. 2, the dosage. The power of light determines the response. Too little, not enough. Too much, adverse effect, producing heat. I don't want to produce heat because in my mind, if I have a heat-generating laser, yes, it's hot. How hot? They're not sure. Why don't I want a heat-producing laser? Too much blood flow. Too much blood flow, heat. Do you heat an acute condition? I think the consensus would be no. Do you heat an entrapped nerve? Probably not. The only time you may consider heat viable would be in a chronic condition, which is 1 out of the 3 types of conditions we see. Light therapy will produce the right amount of intensity to allow the cells to heal from the inside out. And of course, the delivery mechanism. The key is coherent, focused light, ensuring appropriate tissue stimulation. 635 is the key wavelength because it's the frequency of a healthy cell, absorbable dose. It is visible life. It is where DNA replication occurs, which the word photobiostimulation comes from, and it's 20 times more effective than longer wavelengths. This study really showed that low-level laser therapy accelerated tension healing, increasing fibroblastic proliferation, leading to collagen synthesis. The 635 nanometer light produced a higher deposition of collagen, increasing tensile strength of completely severed and surgically repaired rat tendons. key component, the outer cell membrane we call the cytochromes, but the inner cell membrane, which gets stimulated from the 635 wavelength, is cytochrome C oxidase. That's the key component. That is essentially hitting home, if you will. So as long as we can stimulate CCO absorption, we're going to pierce and penetrate the cell. Because by far, it may be considered a mitochondrial photoacceptor. We've shown in literature that 635 nanometers has the ability to influence mitochondrial enzymatic reaction, particularly CCO, leading to mitochondrial activity and efficient ATP synthesis. The frequency, people talk about the beeping of light. It essentially is the beeping of the red light. It's a number of flashes per second. It is the modulation of light that will enable people to overcome clinical plateaus. FYI, the frequency of 30 or less is visible to the naked eye. It's visible to the naked eye. Over 30, the pulse is too fast to see, and it appears as continuous. So when you look and you put it on your hand, you'll see one beeping and one looking straight. That straight one has a frequency of over 30. For me, my big Fab 5, when a patient walks in, very simply, number one, joint dysfunction. I always look at joint dysfunction first. Number two, as I go from the inside out, I look at the extracellular matrix. Once again, the cartilage, the tendons, the ligaments, and the fascia. Always seeing and determining if the patient is exercising, how they're performing their exercise, their ergonomics. Are they having any proprioception, and what proprioceptive moves to increase? Number four, without question, laser therapy. And finally, not last, but quite important, nutrition. Number one, their diet, and number two, supplements to diet. By applying, this is my take, by applying laser energy to affected areas, the frequency sensory nerve firing is increased, which subsequently increases the stimuli to the spinal cord, brainstem, and brain, and in turn decreases pain at the spinal cord and brainstem levels. Do you need a lot of power to penetrate? No. Too much power indicates that it's not a low-level laser. Low-level laser therapy are affecting biochemical, but they're not affecting dermal because they're causing no heat, thereby causing no damage to living tissue. It's sort of like burning the toast when you heat the skin. The Arndt-Schutz law is quite interesting in that he really depicts some interesting things, in that he really talks about biomodulation. He explains that a very weak stimuli doesn't do much. A moderate stimuli favors biomodulation. A strong one retards it, and a very strong one can arrest it. So biomodulation is restoring the cell back to its natural frequency, because as we all know, the body is all interconnected. Andrew Weil really talked about spontaneous healing, and the circuitry and machinery is there. The problem is to discover how to turn the right switches to activate the processes at the right time. I can tell you that laser light is used to turn on the right switches. And what I mean by that is we have something called upregulation. We're turning muscles on and off. We're enabling muscles to be stronger. That is not our end goal when I teach a seminar. Our end goal is to get them to move functionally, because we're now in that 21st century. However, here are some muscle tests that you can do: C1, C2, C3, 4, 5, 6, 7, 8, and T1. You can run through those, and I can split the heads of one of our lasers, which is now the PL touch, or the P5 touch. When we split the heads, we can put one of the heads laser light by the spinal cord and the other one by the nerve root, enabling us in 5 or 10 seconds to get a different result in any kind of the associated muscle test that you see before you now. We also can apply the muscle testing and the splitting of the heads to the lower kinetic chain, going through all the myotomal muscles in the lower body. I'm a big proponent, and I like to break these down a little bit, lasering individual muscles to lead to a functional movement. So some people have a tight SCM. I happen to have it. I have congenital torticollis, unfortunately. So I have extremely hypertonic fibric calcific SCMs with associated scalenes. It elevates my levator trap. I have an adverse effect to my trapezius. We can break these muscles down and laser each individual muscle, like the supraspinatus, the lat dorsi, the psoas, the glute max, the piriformis, and the erector spinae, before we upregulate the whole body into a functional movement. Laser motor lock-in. Just pointing the laser is very effective. Just pointing the laser to get true outcome is not enough for us. I recommend everybody do a laser locomotor lock-in. It's resetting the neuromusculoskeletal system in a 3D motion. The frequency I put up there, people always ask, it's 493360. I like to call it facilitated bodies global integration. You're in a standing position and you're doing what we call a cross crawl, a natural movement, a neurogenically appropriate movement, right arm forward, left arm back, left arm forward, right arm back. We do that for 5 seconds with our eyes open, and then we do it 5 seconds with our eyes closed as we apply the laser light to the posterior midline of the spine. And then after doing 5 and 5, we then repeat by pointing at the brain to get all the integrative altered motor control working together. Besides, as we all know, the brain is the highest level of ATP mitochondria, so why not upregulate the brain at the end of the day? Here is a picture of core motor lock-in. Once again, the frequency is 493360. Everybody that has a lower back injury has a core that is not firing right, and the intrinsic endurance local core muscles aren't stabilizing the spine. So in this picture, I'm depicting a rocker board with Vanessa, my front desk help actually, and I'm lasering her lower back core, and I'm also lasering her anterior core for 30 seconds after a lower back injury. If anybody's interested, I have made a video. It's on my website, drrobertsilverman.com. I put together a functional movement assessment. There's so many movement forms out there. So many people have done a beautiful job, and I've trained under many of them, that I decided to put this together. And I think I used this as a backbone in my office to assess their functional movement. So my Magnificent 7 is very specific in that posture is quite important. I do assess posture. Posture is a shadow of movement. Pain. I don't chase the area of pain. He who treats the side of pain is lost, but I do know that pain is indicative of something being wrong in the system. The overhead squat. The overhead squat is a staple in any movement strain. I can tell you that most people come in and say they can't do it. Everybody should be able to squat because everybody does use the lavatory and everybody does sit in a chair. So they can squat. So it's a question of how they get there is what we need to assess. A one-legged squat. The young lady in the top on the left is demonstrating a one-legged squat below parallel. It can be done. It should be done. We spend more time on one leg than on two legs. Trunk stability push-up basically is testing their core ability to stabilize their core. Valgus jump test is a wonderful test. It's determining if someone's going to turn in valgus lateral and if they're susceptible to an ACL injury. Upper and lower muscle firing patterns are quite critical in that they will determine, for instance, if my trap fires before I raise my shoulder, if my hip doesn't extend 10 degrees, and finally a push-up. If it's good enough for the Marines and the Navy SEALs, it's good enough for me. Finally, functional movement will make the visible invisible very quickly. Movement will never lie. It tells a unique story of every individual's history in compensations and adaptations. So movement or aberrant movement creates adhesions that will limit more movement. Limited movement then will create compensations. Compensations create stress. Ultimately, chronic stress creates more adhesions. And here we have adhesions and lack of movement, and we're in this vicious chronic cycle. So let's talk about some key laser therapy protocols for musculoskeletal injuries. My computer has a mind of its own. Carpal tunnel. My suggestion is to laser at the points of involvement, 3 to 5 minutes. Laser during movement for approximately 30 to 60 seconds. Add laser motor lock-in. Nerve floss is conceivable. Corrective exercise. I believe in a nutritional protocol. The B vitamins, omega-3 fatty acids are a great nutrition protocol for carpal tunnel, mobilize, manipulate joint restrictions, and of course the myofascial release. So essentially you're lasering either at the carpal tunnel or any one of the points up from the carpal tunnel to the scalenes that may be indicated. Typically the pronated teres is one that's very popular with carpal tunnel protocols. There's a picture of all I'm doing is lasering in the carpal tunnel region. Rotator cuff treatment protocols. Laser at the points of involvement, the muscle, the joint, and of course the scapula. Laser during movement, so I'll have the person go through an appropriate shoulder movement as I laser that particular area. I do my laser motor lock-in, which we discussed previously, and any other chiropractic treatment that you deem necessary to aid in outcome for the rotator cuff injury. So we've covered already carpal tunnel and rotator cuff with the Zirconia laser. Here's a study that's shown that actually exercise and laser was more effective than just exercise alone for subacromial impingement. As we know, if we can't cure or positively affect that subacromial impingement, we're going to lead to a rotator cuff tear. So there I am lasering a particular supraspinatus, which is the #1 muscle that's typically injured in rotator cuff injuries, the disc. Well, right now, I could recommend the FX635 because the FX635 is pending a FDA clearance for lower back, which you should get any second. As far as some of the other ones, here is the protocol. When I do the disc, I do a core motor lock-in after lasering in the area, something that you saw before when the patient was on the rocker board and I lasered behind and in front. I always up-regulate people's core. There's a specific nutritional protocol incorporating glucosamine, MSM, omega-3s, turmeric, ginger, boswellia, and the like. Of course, mobilize, manipulate, and you may want to use flexion distraction, decompression, and take care of joint restrictions. There I am with the PL5 touch, just lasering into the particular lumbar area before I do core motor lock-in. Lateral and medial epicondylitis, laser at the points of involvement. Both of these are very interesting in that they're typically considered tendinosis. They're long-term events. People don't have a great resolve with them. Soft tissue seems to be a major player. You laser at the points of involvement. The flexor, being the medial component, typically has 2 muscles, that being the flexor carpi ulnaris and or the pronated teres, where there's typically 6 muscles on the lateral side that are indicated. Laser during movement, laser motor lock-in, do some corrective exercises. Here you'll see the particular protocol as I'm trying to just laser into the lateral epicondylitis or epicondylopathy. Here's a picture of me doing it on the inside. What you won't see in the picture is that I'm doing it on the inside. Vanessa is also moving her wrist so I can get motion with it. Here's a great little slide. This is back in the PT Journal of 2007 where it talked about LLT, reduced pain and improved function. It had a higher quality of evidence than ultrasound, TENS, heat, exercise, stim, and acupuncture. The low-level laser therapy application improved the healing process of Achilles tendons with rafts. Achilles tendon is a very hard tendon to get to heal in a short period of time because of the lack of blood flow. To see an improvement with any modality is something everybody should run with. Here's an interesting study in that the effect of low-level laser therapy in the development of exercise-induced skeletal muscle, fatigue, and changes in biochemical markers. Essentially, the laser was applied to 2 locations, both heads of the bicep. There was an increased endurance for repeated elbow flexion and decreased post-exercise levels of blood lactate, creatine kinase, and C-reactive protein. So we're seeing the increase in muscle strength at the same time depicted decrease in blood markers. So it's working, healing the body from the inside out. Low-level therapy, laser therapy for sports injuries, the conclusion was it is effective for specific sports injuries. This was back in 2013, particularly jumper's knee, tennis elbow, and Achilles tendonitis. This was in a journal, and I have articles that were talking about laser in chiropractic economics, and basically I said most athletes with chronic ankle sprains have a proprioceptive deficit in that injured ankle. Proper proprioceptive exercises, coupled with laser therapy, have enabled many of my athletes that I treat to avoid recurrence so commonly seen with the injury. This was in the Lancet in 2009, and it showed that up to 22 weeks after laser therapy, people still had a resolve by using laser for their neck pain. The International Association for the Study of Pain found strong evidence for low-level laser therapy on the myofascial pain syndrome. So you're seeing the true versatility/diversity that I talked about in slide number 6 with this particular type of treatment. Here we have a study done in 2010 that warrants the conclusion that laser therapy effectively relieves pain of various etiologies, making it a valuable addition to contemporary pain management. Frozen shoulder, and I can tell you it is a very difficult ailment, having seen and treated so very many of them, so vast in the female population. The conclusion to this study was strong evidence for the effectiveness of laser therapy. Here we have another study showing a positive outcome with low-level laser therapy on TMJ. Interesting here that low-level laser therapy helps stem cells to regenerate tissues. Essentially, when you look at the bottom, the doctor from Harvard had a team that used a low-level powered laser to trigger human dental stem cell to form dentin. Now, hard tissue like that is extremely similar to bone and makes up the bulk of our teeth. So therefore, they outlined the precise molecular mechanism involved and demonstrated its ability using multiple laboratory and animal models. This was a true breakthrough study for low-level laser therapy. Neurodynamic tests. It's something that I do. I'm making a video on that right now for all that are interested. Essentially, it's a way to determine if there is tension through a nerve in a particular area or through a nerve through its whole course that it runs through the body. So I threw that in to let people know that chiros, manual therapists, can use low-level laser therapy. If you wanted to laser nerves or at the nerve area, here's a chart that's wonderful. At the brachial plexus, clearly the scalenes. The median nerve, the two most common areas would be the pronator teres and the flexor racuniculum. The ulnar nerve, you would most commonly get between the olecranon and the medial epicondyle. The radial nerve would be most common at the triangular space between the teres minor, the long head of the triceps, and humerus. Sciatic nerve, great spot, piriformis. Femoral nerve through the psoas. The tibial nerve typically posterior to the knee. The peroneal nerve, medial biceps femoris, head of the fibula. The sural nerve at the calf region, and the tarsal tunnel, specifically at the tarsal tunnel in the foot ankle region. To piggyback on this, here's a particular part taken out of a book where we see the effect to action a wavelength for potentiation of a nerve occurs between 540 and almost 635 nanometers. 904, 660, 830, 880, and 950 have no effect. So to piggyback once again on what I said earlier, a hot laser isn't going to really lead you down the road. It's going to adversely affect the action potential of a nerve, whereas a light laser will positively affect the action potential of a nerve. In the interest of time, I would have loved to gone through this particular slide. In a nutshell, cell membrane health is a key component to patients' recovery and a key component to enable the laser to work even better. The big problem is we're always fighting between omega-3s and omega-6, so the takeaway is we always want people to eat more and more omega-3s to have a better, positively functioning cell membrane. Lasers should be directed to the effective site. In a nutshell, photons enter the tissue. It alters our cell membrane permeability. We then get cellular photochemical reactions. This is going to get absorbed into mitochondria. The mitochondria will produce ATP. When they produce ATP efficiently, they produce less free radicals. The resulting effects are very simple: increased metabolic activity, vascular activity, and decreased inflammation. I'm a big proponent of always having simple strategies first. That does look like my old college roommate. Choosing your next laser. To try and conclude, regulation considerations. If it's not FDA cleared, don't consider it. If it is FDA cleared, ask what it's FDA cleared for. Therapeutic factors, the dose and frequency, the wavelength, the power, the modulation. So we don't want it too high. We want it lower level power. Wavelength we've really established, 635. The non-therapeutic factors. Is it portable? The size and the weight. Is it corded? Can you carry it around? What does low-level laser do? It stimulates both the nervous system and the site of the tissue injury. It is clinically proven to suppress inflammation, increase oxygen and blood flow, promote calcium uptake, and increase neurotransmitter release. So in the end, I call it my Dr. Rob's Sexy Six. Laser delivers light energy. Lasers can stimulate cell activity. Laser is classified based on its power supply. FYI, anybody over a level 3 laser must wear goggles or glasses. Level 4, the FDA requires them to have a special room. Level 2 or less, the blink reflex protects the eye. We don't have to wear glasses. Wavelength is the length of the wave of light energy. The kinds of tissues treated depends on wavelength and power supply, and as Clark is everything in our life, in our world, laser companies don't always agree. So hopefully everybody can adhere to Oliver Wendell Holmes in that a mind once stretched by a new idea never regains its original dimensions. Hopefully we have some stretch marks on these webinar attendees, and I am open to questions now. Hopefully you all enjoyed.
Thank you so much, Dr. Silverman. This was extremely informative. We've been collecting some questions from the audience, so I will go ahead and get to those now.
Great.
All right, so one doctor asks, is there any downside on a cellular level to the stimulation of ATP production if done at frequent intervals via low-level laser therapy?
That's a fabulous question. And when you say frequent intervals, and if you want to re-email or contact me at info@drrobertsilverman.com, that would be fine. When you say frequent intervals, I'm usually lasering people, once a day or once every other day. So on those intervals, no. And the fact that we're stimulating the ATP really theorize what we're doing. The whole goal of ATP is the energy that's needed. So think of the muscles that we're able to get to contract more. Think of the organs that are ATP oriented, the brain, the cardiac muscle, and the liver. And now that we talk about the efficiency of the ability to produce ATP and not producing free radicals, we could almost theorize it's sort of like anti-aging.
Fantastic. Are you ready for the next one?
I'm ready.
All right. I think we got time for one more. Another doctor asks, is low-level laser therapy helpful for hypotonic syndrome? And the case at hand is a child, now 1-year-old, who is deprived of oxygen in the birth canal, and he's wondering, can LLLT accelerate recovery of nerve function?
I'll be honest with you, I have never had anybody with that in my office, so all I'm going to say to that or speak to that question is you could try, but I haven't tried it on that condition. I'm really sorry.
All right. Would you like to do one more?
Yeah, let's do another one.
All right. Do you have to touch the skin with the laser?
Great question. It is better to touch, but you don't have to. As long as with low-level laser therapy, you're within 3 to 5 inches, you're in the realm of possibilities. So it's excellent. You don't have to touch it. Theoretically, you could be on the other side of the room. I would never do that. I would stay within 3 inches and or touch the skin.
Okay, thank you, Dr. Silverman. At this time, we would like to thank our sponsor, Arconia, and Dr. Robert Silverman for today's webinar, and thank you all so much for attending. Remember, this webinar, including our speaker's PowerPoint presentation, is being recorded. So if we didn't get to your question during the webinar, the questions will be posted to our expert, and the answers will be posted shortly on chiroeco.com/webinar. We'll alert you all when the webinar is available online. Thank you again for attending, and we look forward to seeing you next time. Have a wonderful day.
Are we off?